You're listening to In Sickness, a podcast about caregiving with Allison Breininger and Justin Bima. Hey, good morning, Allison.
Good morning, Justin. I have been so looking forward to this conversation. We have a guest today. He is a palliative care doctor. And before we get into introducing him, I just want to sort of tell my history and Sean's history with palliative care. This was a long time ago, years ago. And when we were dealing with Sean's transplant and some cancers, and I remember very clearly like where I was when I got an email from a friend who's a nurse, not our nurse, just a friend of ours, and said, I'm going to say something to you, and I don't want you to take it the wrong way. Mm-hmm. She said, I think that Sean should look into palliative care. And she said, but wait, it's not what you think. It's not, it doesn't, I am, and it's true. I'm glad she said that, because as soon as she said that, I thought she knows something about his health that I don't. Like, she's trying to tell me that he's at the end and that we need this. Because I think often we think of palliative care and we think of hospice or end of life. She said, it's not that. And so she explained a little bit more about what it was. And then we looked into it. And then since then, Sean has palliative as part of his care team. It is absolutely our favorite department and our favorite care team. And whether we're in the clinic or we're at the hospital, we always get a consult. And I just hear that there's a lot of confusion around it and a lot of people who are, not accessing it. And I think that it's like, it has just been such a game changer for us. And so I'm really excited about this conversation. But before we introduce him, I was wondering, Justin, do you have any experience in your caregiving life with palliative? Is it something that you know much about or that Sarah has used?
No, it's actually something that I know almost nothing about. So Perfect. This is going to be good to kind of get some awareness. It's not something that was ever presented to us in our journey. I don't know how it would have applied to us in our situation necessarily. Yeah. So kind of interested to learn how that goes. So that being said, let's introduce our guest here. We have Dr. Drew Rosielle, who is a palliative care doctor in the Twin Cities area. Thank you so much for being here.
Yeah, thank you so much for having me. Looking forward to this conversation.
Great. So tell us, how would you define what palliative care is, kind of what it does, and how it is, I guess, the same or different from hospice?
Sure. Palliative care is complicated, and it means different things in different places. And so what I'm going to be talking about here are, I think it's best to understand as specialized palliative care programs in the U.S.
Okay.
So most of what I'm going to say is kind of applicable to things under that umbrella. Mm-hmm. So specialized palliative care programs in the U.S. are typically interdisciplinary teams of healthcare professionals. The mix is a little different depending on where you are, but it can be doctors, nurse practitioners, nurses, social workers, chaplains, physical therapists, other folks like that. Interdisciplinary teams that are really focused on maintaining and improving the quality of life for people who've got serious health conditions, serious illnesses. What's a serious illness? Mm-hmm. And I'll just freely admit that serious illness is a euphemism that is used all throughout medicine, including in palliative care. But in general, it means an illness that has a high risk of mortality or sort of serious chronic symptom burden and morbidity. And so it can include cancer. It can include significant other organ diseases, heart failure, emphysema, other lung problems, end-stage liver disease, can include dementia. This list is not supposed to be exhaustive, but diseases that are highly morbid and most of which have a high risk of mortality. And so it's really interdisciplinary quality of life care for folks and their families going through that. I want to emphasize that when I say a high risk of mortality, I don't mean terminal illnesses, right? Okay. So and at least, casually speaking, right, a terminal illness, I think most of us conceptualize that as a disease that is incurable, that is inevitably going to get worse and end someone's life eventually, right? So that's what I mean by terminal illness. And palliative care, while we care for many of our patients who have terminal illnesses, it's also for folks who don't have terminal illnesses, but like a high risk of mortality. Just to get some examples, might mean someone who's got, let's say, leukemia, which, depending on the type of leukemia, maybe they've got a 50-50 chance of a cure, or dying in the next few years. And they may be getting curative treatment that's got a fighting chance of curing them. And palliative care is absolutely available to them to help with quality of life issues while they're going through that. It could be people with significant organ problems, heart failure, lung failure, liver problems, who maybe are hoping for a transplant, or maybe will get a cardiac support device that will transform their lives for the better, and they won't really be terminally ill. But while they're going through that, they're having significant quality of life impairments, and palliative care helps with that. Palliative care happens in the hospital as well as clinics and homes. And so if you can imagine people in the hospital in an ICU, let's say they've got overwhelming COVID pneumonia. And they're really sick and they're on a ventilator from that. Palliative care teams might be there to help with symptom management during that and to support families during that. That patient doesn't have to be terminally ill. And many of those patients with severe COVID pneumonia, thankfully, will recover. Mm-hmm. But many of them won't either, right? So that's what I mean by life-threatening, but not terminal. So that's what these specialized teams are really focused on.
Can we do a quick little vocabulary bank here for a second?
Please.
So I'm hearing morbidity, I'm hearing mortality, and I'm hearing terminal, right? So what's the difference between morbidity and mortality?
Yeah, thanks. Mortality means death or dying.
Right.
So a disease with a high risk of mortality is a disease with a high risk of death associated with it.
Yeah.
Morbidity, thanks, Allison, means like symptom burden, means disability, functional impairment, difficulty walking, doing the important activities in your life.
Okay.
Taking care of yourself, going to work, being a spouse, parent, sibling, child.
Sure. Okay. Thank you. That's helpful. Yeah. So if you go back to, I'm sorry, I interrupted you. But if we go back to even thinking about that example you had about someone's in the hospital and they've got COVID pneumonia, and you said your team could come in, like what is it that your team or their palliative team, with all those different types of people, would do for that person that's different from what their other doctors might be doing?
Great question. And in general, the aspects of care and that palliative care teams are addressing for patients and their families, their loved ones, whomever that is, are things related to symptoms. So whether that sometimes, physical symptoms, pain management, breathlessness management, nausea, vomiting, other physical symptoms that go along with having an advanced illness or a life-threatening illness or whatever it is. The second main thing that the palliative care teams typically looking at is emotional support. So supporting the stress and the grief and the worry that goes along both with families and their loved ones as they're going through this. And so again, what that might mean, it often means is offering counseling. So whether in the hospital or whatever, but counseling done by a social worker or other trained counselor to help with, again, the stress, the worry, the grief, the loss that goes along with having a life-altering diagnosis or a serious medical illness or being in the ICU or whatever it is. And the third major sort of pillar or bucket of things that palliative care programs do is and this is especially for patients who do have life-threatening illnesses and may not survive, is what people, I guess, broadly call care planning. So let's say I've got a patient who's got leukemia, which is a type of blood cancer and certain types of leukemia have, let's say, like a 50-50 chance of being cured. Versus a 50% chance, for instance, of someone not being cured and dying within 1 or 2 years. So really, really, really high risk diseases. So care planning for them would be, if they want to, talking about educating them about if the leukemia does become untreatable, what is it going to mean for your life? What sort of things are you going to go through and your family's going to go through? What you can do now to be prepared for that. Practical things as well as a sort of emotional, existential things that people might want to do to be prepared for that. That's what I mean by care planning is talking with patients about what their futures might look like and helping them think in a practical basis about that, about like, well, what do I need to be doing anything now? Do I need to be doing wills or healthcare directives? Do I need to be talking to key people in my life? Do I need to be preparing my kids? You know, is giving, we're a team that has a lot of expertise in helping people think that through.
Yeah.
Yeah.
And our last, the person we interviewed was a death doula. And so we have been having lots of conversations around things like that. And so it's helpful to know that, you know, this is another team that can help. And we have just been talking about how, like, we don't all talk about death. Nobody talks about death. And whether you're a caregiver or not, we got to start these conversations. And so it just feels really helpful to know that there are teams out there that can be facilitating those conversations for us, because it can be a hard thing to start, a hard conversation to have. So in our experience, I just feel like you can almost sense the person who's from the palliative team before you even see their name tag, because there's something different. I feel like when we're in the hospital, the palliative team is the one that comes in, they grab a chair and actually sit at the bedside instead of sort of looming over Sean. They're the ones that look at me as the caregiver and say, how are you doing through all of this? Right? There's just a different vibe around the people that we have encountered on a palliative care team. And so, I mean, I guess part of it is like what you said is bucket number 2. I mean, I almost want to cry just thinking about you saying bucket number 2, which is the emotional support, which is, I think, what is so often ignored and forgotten, is that we start with bucket number 1. Because when you were saying bucket number 1, I was sort of like, well, other doctors are supposed to help with your breathing and your pain management, right? Like, how is this different? Oh, no, it's bucket number 2, right? And so can you talk about that and about how does that happen? And why is it that your team, you know, your palliative teams in general, are so beautifully gifted at taking care of that emotional part? And why can't that be true of all the medical professionals? Like, what's the difference there?
Yeah, that's a great question.
That's $1 million question.
It's $1 million. Yeah. And I you know, why other medical professionals are perhaps less prone to address those needs or those things that are going on with our patients and families. It's a really tough question for me to answer. And I don't know, you know, I don't have a quite an easy answer to it. But what I would say about it is that, you know, why a palliative care teams like this is because, well, it's because it's central to who we are as palliative care specialists. You know, a trained palliative care nurse or nurse practitioner or a social worker or a doctor, a huge part of your training is really learning how to be really focused on the emotional experiences that our patients and their families are going through. And I just want to, I'm probably going to say family, and I just want to acknowledge that I, of course, mean family broadly. I mean, loved ones, caregivers. It doesn't have to be legal family. Sure. And so, you know, I was an internal medicine doctor, and then I did an extra year of training in how to become a palliative care doctor. And quite literally during that year of training, a big part of what I was taught was how to have these discussions with people about mood, coping, meaning, fear, grief, loss, etc. And I'll observe that, you know, when I went through my internal medicine training, I cared about these things. I mean, I didn't not care about these things. You know, like, I appreciated, like, this is really awful for what my patients are going through. This sucks for them. Like I knew that, and most doctors know that, I think. I'm sure. But I didn't really have the skills in how to actually talk to people about it in ways that were at least vaguely or therapeutic and helpful for people. And so we're trained to do it. I mean, just to be practical about it. Like, and there's an idea out there that I hear in amongst my colleagues outside of palliative care, is that, you know, these sorts of things about, you can't actually train them. Like, you either got it or you don't. And I just really strongly believe that's not true. Like you can learn how to talk to patients about mood, grief, existential stuff. You can learn how to express your own compassion and caring for a patient or their family. These are all learned things. The final thing I'll say about that is that those of us who work in palliative care, you know, when we're walking into patients' rooms in the hospital or whatever, fundamentally our task is not to like figure out how to keep this poor patient alive or whatever it is, or and that task is really important.
Yeah.
How someone who's critically on the hospital or seriously on the hospital, and I'm really grateful that there are so many doctors and nurses and surgeons who are laser focused on that. But when I'm there and when my colleagues are there, like that's not really our job. No one called us in this room to like, dear God, you got to save this guy's life, right? That's not why we're there. We're really our role is to figure out is the patient suffering in ways that we can help, treating a symptom, but also engaging and supporting the patient and family emotionally, existentially. Again, trying to give some space and some breath and to humanize the experience they're going through. Like that's actually our task there. And the fact that we don't have to worry about also saving the patient because we're trusting our good colleagues to be doing everything possible to do that, gives us sort of the space and the perspective to really sit with that stuff with folks, if that makes any sense.
Yeah, I think so. And not that other doctors aren't this way, but it really feels like what you're doing is like seeing the whole patient and their whole experience through that versus like, here is a disease or a diagnosis and laser focused on that and dealing with that. But like you're there for the whole experience of it, which I think is a really potentially powerful resource to have available to you. I can't help but think, my wife, Sarah, spent 3 years pretty much bedbound due to her chronic illness. And
wow,
that was really a difficult time for both of us. And I don't know that, not knowing a lot about palliative care, I don't know if that would have been a resource that would have helped us or how that would have helped us through that. But it was something that was never presented to us in our interactions with her healthcare folks. It just wasn't ever brought up. And so I'm just kind of curious at what types of patients or at what stage in someone's care do they typically first get their interactions with palliative care, or at what stage would they potentially benefit from that?
Yeah, great question. I think the overly simple answer is that like, well, whenever they need us. But of course, well, what the heck does that mean on a practical basis, right? So a couple things about your great question, Justin. I'll observe that the things that we do in palliative care aren't exclusive to us.
Right.
Other medical professionals, doctors, nurse practitioners also care about symptoms and treat them. For sure. Frequently are talking about mood and coping and stuff like with that and preparing the patient. So, I think what we do in palliative care, we're really doing it as specialists who do that, who are being brought in on situations, patient situations in which there's a clinician, a doctor or nurse practitioner or whatever, who's like, boy, I really need help with this situation. This patient's really suffering. I'm not doing a good job of helping the family. I need help. Right. And so we tend to get, palliative care, specialized palliative care programs get called in on those patients who need that extra help with it, which is not 100% of everyone with serious and chronic illnesses for complicated reasons, including there's just not enough specialized palliative care programs out there. So part of the question let me say that. So in my practice, I'm working mostly in a cancer center, although not all of my patients have cancer. For the most part, the patients I see, I'm seeing because someone on the cancer care team was like, this patient's still struggling with all this stuff, despite what we're doing. Let's bring in an extra layer of support to help with particularly tough to manage pain or other symptoms, particularly complicated or challenging mood coping situations. Young patient with a serious illness, family with young kids, someone who's got PTSD and a really high degree of psychological suffering going along with their cancer or their liver problem or whatever it is, right? So we get called in on them, and so that we're the team that kind of does that as a package. there are other folks who help with these things too, right? There's obviously psychologists and health counselors who help people with mood and coping and the grief and loss that goes along with having a chronic illness and a serious illness and things like that. In the U.S., so the practical answer to your question, Justin, really it kind of is related to historical reasons into the U.S. as sort of how palliative care developed.
Okay.
And palliative care developed for historical reasons in the U.S. really aimed at folks with cancer and folks with life-threatening organ failures, heart failure, lung failure, like emphysema, liver failure, and brain failure, like dementia and other sort of life, potentially life-threatening or terminal brain diseases. So the specialty that I'm a part of, and that the most palliative care programs are a part of, really evolved in the U.S. in the 90s and 2000s to care for that cluster of medical conditions. And so there's also many other, however, like very serious medical conditions that those of us in palliative care aren't particularly trained and equipped to help with. And just to give an example, which is I think will be a nice example. Let's talk about someone who's got really refractory schizophrenia. That's a life-threatening illness that causes tremendous suffering on the part of the patient and their loved ones, and really requires careful interdisciplinary care from doctors, psychologists, social workers, etc., care managers to really comprehensively care for someone who's living with refractory schizophrenia. And programs that do that well are godsends and excellent. And they're not palliative care programs, right? They're these mental health squads and teams that many communities have. And so I bring that up as an example of that, the sort of patients that historically that we care for in palliative care are mostly those ones with cancer and those big ticket organ failures.
Something that I am feeling come up in me as I hear you talk is that I think that when people, because like I said, we are seen at a large medical institution with a good reputation, right? And we found out about palliative through this friend, right? And so I started, when she said you should look into palliative, I started Googling it. I was picturing this other separate place we were going to have to go to. And I was like, wait, what do you mean? Like it's here? Like it's in the same building, like it's down the hall. Right. And so when you were talking about that, I was thinking about like other teams, referring people who need extra help, and anybody who has, spent much time with Sean and me, I think they probably see us as like, we're, well educated and well resourced and all of this stuff. And it just makes me sort of think like we probably would have never been referred, because people are probably like, oh, those Breiningers, they got their stuff together. They're probably okay. You know what I mean? Mm-hmm. But yet I'm so glad that we dug up and we found it, because it's been so valuable. And so it just sort of makes me think about all of us caregivers who just we're doing this really hard work and holding it together. But by holding it together, we look like we've got our stuff together, and that maybe we or our person don't need that extra help when really we do. But I don't know if that makes sense, but that's just something that's kind of coming up in me, and that I feel like there have been a lot of resources like that we find out in other ways that nobody has referred us to. And I think it's just because potentially we seem like, oh yeah, they don't need that stuff. They're good. And it's like, no, we really just because we still need it too,
Yeah. Yeah. That's a remarkable observation, isn't it? Right. That the attributions that people can give to how well you're doing and what you quote unquote need based on social class, socioeconomics, class, race, where you live. I think all those are really alive in healthcare and affect us in palliative care as equally as everyone else, of course.
Yeah. Yeah. So can I clarify, because it sounds like two different kind of things going on. That sounds one that it's interdisciplinary. So there's a lot of different types of people on your team that someone who has access to palliative care can then have access to. But it's also that the people on your team are trained differently. Mm-hmm. Right. So some of you are supporting pain management, but doing through a different lens and a different, sort of way. But also, so it's not just that like I'm going to, have access to a doctor who's going to also care about my emotional support, my emotional state. But it's also that then I know that Sean saw someone who did a lot of like hypnotherapy with him, which was so cool, or like they would come and do like a little hand massage while we were in this place, and so it's both, right? It's lots of different types of people, but different types of people who are also have this extra training to be emotional support. Is that accurate?
Yeah. So like, so I'm a physician, so I come at it with a physician's training, and nurse practitioners come out with a nurse practitioner's training. And you can imagine social workers come at this with incredibly different background and training. And our chaplains, obviously in different professional background and training as well. In the chat, and so just to, for instance, palliative care teams with chaplains, they're not prescribing pain medicines to people, for obvious reasons, but they, I think in general, most well-run palliative care teams with well-trained professionals on them, everyone on that team is going to be inquiring and asking about and caring about and troubleshooting all of those domains, physical symptoms, pain, breathlessness, nausea, because our chaplains might do Reiki, or they might do healing touch, or they might do centering prayer, whatever's appropriate for the patient and the chaplain's trained in to help them, to calm their body, reduce, which reduces pain, and etc.
Yeah.
The chaplains care about that. Although what they bring to it is different than what the nurse practitioners bring to it. Sure. You can just imagine how it kind of cuts across differently in the different professions. But so within an interdisciplinary palliative care team, everyone absolutely, they have different things that we do, but we all are addressing those three domains as relevant, right? Again, some of our patients might be coping great, and all they've got is pain from a bone metastasis. I meet patients all the time who have no pain, or their pain is fine with Tylenol. They're coping great. They're not depressed, they're sleeping, but they have profound, existential distress. Why is this happening to me? How could this happen to me? How can I find meaning in the world with this horrible illness happening to me? Right? That's what they got. And Dr. Drew, I don't have any easy fixes for that. There's no pill for that. Although weirdly one day there might be, but that's a different story.
Yeah.
So those, that's someone that I would, when I'm talking about that, I would say, hey, we've got members of our team who might be able to help with some of this. Additionally, can you meet the chaplain today, or whatever it ends up being.
Yeah.
So we've talked a lot here about how these palliative care teams support the patient. And so I'm kind of curious what these teams can offer for caregivers, and maybe is there any specific training that you get for this in how to support caregivers through this as well?
Yeah, it's so fundamental to the training and perspective that you get when you're kind of specializing in palliative care is to think about the patient and their family, defining family broadly, as the unit of care.
Okay.
We're really socialized and trained in it to think about patients and caregivers together. For reasons that I'm hoping are obvious to everyone listening to this, right? Because caregivers are central to what happens with patients and their well-being and everything. The different members of the team support caregivers in different ways. As a physician, I'm not prescribing pills to the caregiver. I might prescribe a pill to a patient, but as a physician, I'm supporting caregivers by taking extra time to better explain what's going on. Because lots of patient families, even though they've heard it a few times before, still have tremendous questions and good unanswered questions and things that they need clarification on. And so I do a lot of that. I look at how the caregivers are feeling and how they're coping and are they still on their feet and are they sleeping? Because if they're not, I'll I'll offer at least to bring in, for instance, our social workers to help do a more comprehensive home assessment and caregiver coping assessment, and then from there they will, offer things that will help with that. That's kind of how it works.
So are those things then accessible to, so part of it is like in the appointment, turning, how are you doing, Allison, kind of thing. But like, is it like, then do you prescribe, like if you thought that the caregiver could benefit from hypnotherapy or something like that, do they have to be set up as a whole separate patient? Do you know what I mean? In the system to be able to access those things?
Yeah. And that's a great question without a simple answer. The answer to that's going to be really local.
Okay.
So where in my clinic, where I practice, the answer to that would be, I don't practice at elbow with a social worker. I wish I did, but that's just not how it's set up. And so I would, talk to the caregiver and say, hey, our social worker will call you in a day, and you'll go from there. The way palliative care is set up and actually sort of operationalized varies place to place, region to region, institution to institution, hospital to hospital, so to speak.
Sure.
And so there are also programs in which caregivers are there working at elbow, so to speak, in the clinic with a palliative care nurse practitioner or a doctor, and the social worker would be right there in the room, and they'd all be together doing this together. Okay. And so yeah. That's pretty heterogeneous as far as sort of what happens in different hospitals and clinics around the U.S.
Okay. So that leads me to ask, so what if somebody's listening and is like, my person would really benefit from this? Like, how do they go about finding palliative care in their area?
Yeah. So all the ways, I guess, is the answer. So I think the idealized way that we all wish like it worked this way, but I'll also say, Allison, like it really does work this way sometimes, is that they should talk to their main doctor.
Okay.
And one of the key doctors taking care of the patient, and ask, is there a palliative care specialist clinic here or whatever, or team available in the hospital, and can you involve them in our care? That's the way it's quote unquote supposed to work, and I think it does work like that a lot. I meet people in clinic who heard about palliative care from, their cousin, and then asked their liver doctor, hey, can I hire palliative care? And the liver doctor's like, oh, sure. And then sends a referral, and I see him a week later, and it's all good. And same thing happens in the hospital. The challenge with that is that the doctor may not know. And I think that, I guess answering this question is wrapped up in sort of how specialty care works in the U.S. and the fact that specialty care isn't evenly distributed. So if your loved one is being cared for in a large health system that's got a lot of specialties and stuff like that, in most parts of the U.S., there will be palliative care teams there that you can access. But if they're being cared for in a smaller system where there's not a lot of specialists, in a rural area, for instance, it's going to be unevenly distributed. Overall, access to palliative care in the hospital is pretty good in the U.S., especially for hospitals that are larger, 100 plus beds. Access to palliative care clinics is quite heterogeneous, meaning that there's so the Twin Cities has a lot of palliative care clinics, but if you were in Fargo, there's a lot fewer per capita, for instance. And so there are those barriers. The Center to Advanced Palliative Care, CAPC, has a spin-off website called Get Palliative. I think if you just Google Get Palliative, their website will pop up, and they have a directory of palliative care programs, including clinic programs across the U.S. and how to access them. But sometimes it does take legwork. My one fundamental bit of advice is do not call your insurance company and ask them like, who do you cover in palliative care? it's for complicated reasons, but I opened this discussion up, so I might as well tell you those complicated reasons. The reason is because there are seeing a palliative care nurse practitioner in a clinic, for instance, is basically identical to seeing an infectious disease doctor or nurse practitioner in a clinic. It's just like any other specialty. Mm-hmm. Right. And there's really no insurance barriers to seeing someone like me in a clinic or in the hospital. But many insurance plans now have these very niche, specialized palliative care benefits, which are mostly focused on advanced like healthcare directive completion and social work assessment done in the home for people who are really sick and kind of homebound or getting there. And insurance companies have these benefits, which they call palliative care, which are good benefits, but they're about like a social worker will come out a couple times to do a healthcare direct with you. And that's nice. But when the insurance company rep looks at palliative care in your plan, that's what they will see. And as you can imagine, like the person that's answering the question about like, is palliative care covered? Like they don't really understand what palliative care is.
Sure.
And I've had multiple patients tell me, I was worried to see you today because I called my insurance company and they said they'll only pay for like 3 social work visits in 6 months if my loved one was homebound.
Right.
And it breaks my heart to hear that because they've got all this worry about bills that they can't pay and stuff like that. But the top level story there is that palliative care in a clinic or a hospital is always covered by insurance.
Always?
Is always.
Wow.
Yep. I will not qualify that.
Wow.
I will say it's always covered by insurance. The palliative care stuff that happens at home, which is a sort of this, it's a very growing and changing and sort of rapidly, there's a lot of quote unquote innovation happening in that space right now in American healthcare. That's very, very different and it won't pay for a lot. And those benefits are very unevenly distributed as well. But seeing a palliative care doctor in clinic, being seen by a palliative care nurse practitioner or team in a hospital, I will say that is always covered.
Okay.
Yes.
How often do we hear that sentence? Never. It just feels like it can't be true because that's never the case.
Well, we're gonna hear about the one case in which it was.
I know. You get ready. Ready.
Yeah.
To try to kind of paint some pictures for us, because I'm thinking about someone like we have a lot of listeners who are caregivers like Justin, whose spouse has MECFS. Are you familiar with those acronyms?
I am.
Yes.
Yeah.
Okay. I assume, but just,
Yeah.
And, and so their life looks like that. We also have a lot of listeners whose person has dementia, and you mentioned that as well. And so could you just do 2 quick little like examples of like, what if it is like, let's say a 40-year-old person who's pretty, homebound, low, not able to even bedbound, let's say, with MECFS. Is there something like what might a palliative care team be able to support that person with?
Yeah. Realistically, so for someone with MECFS, I think the things that the palliative care program would be most equipped to help someone with would be the second and third pillars, meaning patient and caregiver mood, coping, grief, existential distress, etc. And then care planning. I don't think that MECFS is a disease that goes all sorts of places and can get better, but not always. Care planning is quite unique for it. But for someone who wanted that help, what if this doesn't get better? What if I'm even worse off in 5 years? Not every patient, but at least a large minority of patients worry about that and want to talk with someone knowledgeable about that. I think that's something that palliative care programs would be able to do. Mm-hmm. Dementia, certainly the second and third pillars, mood coping as a second with patient and family and caregivers, and then care planning. Dementia is a bit more predictable than MECFS and is a terminal illness, although it's a terminal illness that may take 8 to 15 years to end someone's life, at times at least. But there's a relatively there's not a single pathway forward with the dementia, but there's a lot that we know about is likely to happen to someone with dementia that we can educate people on and say this is what these sorts of things are likely to be happening in the next 3 to 5 years. This is what I think you should prepare for. Here's some practical things you should be putting into place now, etc. Mm-hmm. Dementia, and I would say that palliative, there are sometimes some of the first pillar things with dementia, meaning, and those are sort of to do with physical symptoms, pain, but a lot, mood stuff, sleep disturbances, and all that. Mm-hmm. Palliative care teams are definitely involved with those. So, as are primary care clinicians, sure. As are neurologists who treat dementia, we don't own that. In the sense that we're the exclusive specialists who does that. Lord knows that is not true. Right. But but that's certainly something that we do alongside primary care and neurology, dementia neurologists and etc. Geriatricians, of course. And
yeah. Okay. And so when you talk about care planning in bucket number 3, it's not necessarily just like end of life care planning. It could be like, okay, I'm in this thing for the long haul, and my life is going to be impacted for a long time by this disease. So how can I plan in that way? Yes, you're
great call out. That's right. It's not just end of life care planning. End of life care planning is, again, really important for people who want to do it for folks who have terminal illnesses. But a lot of folks don't clearly have terminal illnesses. They've got serious illnesses, and so it's to do with a lot of care planning is to do with like living with chronic disability.
Gotcha.
Mm-hmm. And huge. Sort of more in that general domain. Than it is end of life care planning. Yeah.
Okay, I'm glad we clarified that.
Yeah. That's good. So kind of as we wrap up this discussion, one, I just want to. It's wonderful to hear from someone in the medical profession like, we look at the caregivers as an integral part of the situation. Like that as a caregiver is really meaningful to hear. And I really appreciate that. Mm-hmm. What is it that you want to be sure that caregivers kind of hear and know about palliative care?
Great question. So depending on your doctors or nurse practitioners, your medical providers, depending on their background and their training, palliative care may or may not be on their radar. And so it's okay to ask. Like, please ask. And I meet patients all the time whose, major doctor didn't think of us once, but the patient or family members asked, and they're like, oh, okay, sure. That sounds like a good idea. And our program ends up being really helpful for them in important ways, so just don't assume that people are thinking about it. We never talked about what palliative care and hospice is.
Oh yeah, please go ahead.
And I don't know if we want to talk about that before the time runs
please.
Out.
Yeah.
So the specialized palliative care programs in the U.S., again, for the most part, are for anyone who's got that serious illness. Mm-hmm. That illness that's going to cause significant chronic disability and or is life-threatening. Not necessarily terminal, but life-threatening, right? And we're specialized programs that are there to support quality of life, help with mood and coping and care planning for any patient and family going through that who want our help. Hospice is a great program, but hospice is just very different. And hospice is a very specific package of medical and social services that are for people who are in their final 6 months of life, when what we're trying to do in medicine is keep that person in a safe place, hopefully at their home, but in a safe place and comfortable in their final months of life while they're dying. And so hospice is a distinct care package of social and medical services that are really aimed at helping dying patients stay at home and stay comfortable and die peacefully whenever that time comes. And so when you enroll in hospice, you have to qualify. You have to be terminally ill, such that a doctor thinks you're likely going to die in the next 6 months. But when you enroll in hospice, you kind of trigger all of these benefits, all of these insurance benefits that come in, with aid visits, nurses visits, equipment at home, and things like that, which are really great and essential for folks who are terminally ill. Mm-hmm. But that's triggered by when you enroll in hospice care. Palliative care is just nothing like that. There isn't an insurance benefit that's triggered. There's no package of medical and social services that goes along with it. For the most part, seeing a palliative care team in the hospital or clinic is just like seeing an infectious disease specialty team, except that what we do is a little different. But that's kind of how it works without there being this being this package. 5 years from now, 10 years from now, it's possible there will be a sort of package of palliative care that's available for folks with certain insurances. Like we're in an era of a lot of change and innovation that's happening with palliative care insurance benefits. And so what I'm saying today may not be true 5 years from now, but it is true now.
It's interesting then that those two are confused so often. That you say palliative and then people assume end of life when really you're saying how different they are. And really it's more, is it just because palliative is typically for someone who's got a really serious something, or why do you think it is that confusion happens?
No, so it's a great question. And I'm laughing, not because what you said was trite, because what you said was completely perfect and right. There's the answer to that is really historical. And it has to do with how palliative care came about as a kind of specialty within healthcare, within medicine. And to be really clear about that, hospice came first. Hospice was this movement that started, let's keep it to the U.S. In the U.S., it started in the late 70s, and it was really aimed at helping people die at home and doing comprehensive whole person patient family care for people with terminal illnesses. Palliative care really kind of came out in the 90s when people, most of whom were hospice doctors and social workers, who are looking at what we're doing for hospice people and said to themselves, like, well, geez, like why this sort of like whole person care, mind, body, spirit, family? Why are we only creating this for people who are in their final few months of life?
Right.
Why don't we do it for everyone who needs it? And so palliative care in the U.S. was kind of invented for all those other people who need it, who aren't quite terminally ill,
right,
or aren't necessarily terminally ill.
Right.
But the history of it is that palliative care absolutely kind of was an offshoot, was a branch off of hospice, and we're still living in the after effects of that, but that's why they're so closely associated in everyone's minds.
Right.
There's more to the story than that, but that's the fundamental story.
Yeah. Right.
Yeah.
Right. Yeah. It just, there's a couple of things that you said today that just made me want to just kind of weep, because they're so, like when you said, like, we have the second bucket and we look at the whole person and we look at their emotions.
And I called it a bucket. I'm sorry about that.
What's that?
I'm sorry for calling that a bucket.
No, it's a very important bucket. I love the bucket. I'm always talking about buckets. But that, just hearing a medical professional say that, like, this is something we do. Hearing you say, I'm saying families, and of course I say that because everybody's included. That's not, of course, for everyone, right? So hearing it's so beautiful to hear you say that, like, of course that we know the caregivers and that they're part of the unit, you said, I think. And that's just not the way, like, we're over here fighting to have medical professionals see us as any part of the unit. That's why my nonprofit is called The Negative Space, because we are hidden in the shadows, right? And we aren't seen, right? And so I'm just so grateful that palliative exists, that, and even to hear the history of that is really helpful, and to have them be like, why can't we give this great thing to everybody? And maybe even at some point we'll have part 3, which is not just, why do we just give it to people in their last 6 months, and the people who are really seriously ill, why don't we give it to everybody. Period?
Yeah.
Right.
Mm-hmm. Yep.
Maybe that will someday happen as well. But it just is, I hope that hearing this for caregivers gives them some hope that this exists. It gives them some clarity around something that maybe they could reach out for today and not be waiting any longer. And that there is a team out there, hopefully in their community, that can help both their person and them. And that's just beautiful. So I just appreciate all of the things that you shared with us today, and all you do for all of your patients. I'm so glad that my friend emailed me all those years ago, and that Sean is part of a palliative team, and that's part of the support that he gets. And it's always helpful for me to know, like, regardless of what season we are in with his health, that whatever we're going to come up against, that palliative will be there. And that's really, really helpful to know that. And as his caregiver and his wife, to be reassured to know that that's going to be part of his team no matter what comes up next. So thank you for all you do and for taking time to be with us here today.
Mm-hmm.
Yeah, well, you're welcome, and thank you for having me, and thank you for the work that you two do. Caregivers are central.
Yes,
and I, those of us who do this work, we meet patients sometimes who don't have caregivers, and or functionally don't have caregivers, and our heart breaks, and we, we're so grateful for the love and advocacy that caregivers bring to our patients. We all need each other.
Yeah.
And that's, I think that should be the attitude.
Yeah. Great. All right. Well, thank you very much. It was a great conversation.
Mm-hmm.
Yeah. All right. Talk to you later.
All
right.
Okay. Bye.
Bye. You've been listening to In Sickness. Find us online at insickness.care or on Instagram at insicknesspodcast. You can send your questions and comments to insicknesspodcast@gmail.com. If you enjoyed the show, please share it with a friend or fellow caregiver, or leave us a review on Apple Podcasts. Thanks for listening, and take care.